Welcome, everyone, and welcome back. I think for efficiency, we're going to start. I think many of you are very familiar with Alicia Yamin's talk. And I think for me, I remember when Julio Frank yesterday was talking, he talked about health in terms of the importance as a social right. And I think we've been talking about equity issues and the whole issue of rights. And this is where I think Alicia comes in with her expertise. She's currently a lecturer on global health and director of the program on health rights of women and children at the Francois Xavier Bagu Center for Health and Human Rights at Harvard. She has a number of appointments, and I think one of the interesting things that I found when I was looking through her bio is that she's actually been not just in terms of academically producing a number of scholarly articles and books, but really been involved in dealing with changes on the ground, especially in Colombia, if I'm right, Alicia, and is involved in many commissions and on boards, and sort of a really nice mix of academics as well as activism. So without much ado, I'd like to introduce Alicia.
Thanks very much, Sharmila. So I will just sort of start the talk, and you can stop me whenever the 10 minutes is up. Or, really, I have been pleasantly surprised by how much discussion there is about human rights and universal coverage, about Dean Frank's use yesterday of this paradigm of social rights. It's been in the Lancet series. Simultaneously, at the Human Rights Council, there has been enormous attention to universal coverage as part of the right to health. Devoting in the last resolution that they issued last month 3 entire paragraphs to universal health coverage, and admittedly the WHO had a lot to do with this resolution, but still it's quite surprising, and because it's not self-evident that you would have to look at universal health coverage, many of the as a rights issue. So I want to talk a little bit today, propose that thinking about it in terms of human rights changes the way we frame it and think about it, and also potentially changes some of the decisions that you make along the path to universal coverage. And I think those two things are related but distinct. So in terms of the first one, in terms of how we think about universal coverage and the nature of health and health systems, the right to health was first set out in the WHO preamble. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I am well aware that among philosophers and ethicists, this definition is not entirely popular. It's been called particularly lavish and other things. And from the perspective of international law, it is also problematic. Generally, we think in law of rights as tools or building blocks to lives of dignity, not as end states, as conveyed here. And it's very difficult, as you might imagine, to try to carve out an enforceable entitlement from this broad definition. But in terms of changing a paradigm, of getting away from what is commonly thought of as the biomedical paradigm, it is, I think, immensely important. The idea that health is not just a matter of biological factors, but a matter of social and power relations, denaturalizes disease and conditions, so that you have to take into account things that Dr. Levine's was talking about yesterday, dysfunctional families, gender-based violence. And it's not just that social determinants of health affect species normal functioning. It is that health itself needs to be understood within social contexts. So that, I think, has some implications, as we'll see later, about what universal coverage might mean and how we might approach it. More recently, in the last 10 years or so, there has developed a rights-based approach to health systems. And what that would mean. And I think it was usefully set out by the Task Force on Child and Maternal Health for the MDGs, actually, the group that did that. And they talk about health systems as core social institutions. So not delivery apparata for goods and services, but really much more akin to a justice system, which can facilitate, enhance substantive democracy, or exacerbate inequities and inequalities and exclusions in society. Part of what, fundamentally Dworkin would call a political settlement in a society. So the driving rationale is not the creation of markets, but inclusion and equity through cross-subsidization and redistribution. And patients are not seen as consumers. We heard a lot about this yesterday, people using the term consumers, but as citizens, and I would argue social citizens, not necessarily legal citizens, that is an important distinction, with entitlements and rights, who can claim their access to entitlements, quality entitlements. The state then has a particular role to play in equalizing the playing field, both between rich and poor, but also among different geographical areas, as we heard with inequity in geographical variation. And has a role to play whether the state is a provider of services itself or whether it is regulating private providers. That's a very important thing to keep in mind. And yes, it absolutely favors a universal system as opposed to pro-poor targeting. So I think also human rights law provides some more specific criteria and principles that might help us in making decisions about moving toward universal coverage, although it's far from a recipe or formula. The International Covenant on Economic, Social, and Cultural Rights was really the core formulation of a right to health under international law. And if you look at the Travaux, actually they rejected the WHO definition and used a much more functional, pragmatic notion of what states need to do to progressively realize the right to health, which includes the creation of conditions which would assure to all medical service and medical attention in the event of sickness, but also other things that we would call public health interventions. So it's very important to note that it's the right to health, not health care under international law, and that the right to health is interdependent and indivisible with a number of other rights, both civil and political, as well as economic and social, like education, housing, et cetera. More recently, there have been even more specific treaty-based obligations relating to universal coverage. So this is the Protocol of San Salvador, which is the additional protocol to the American Convention of Human Rights and the Organization of American States. And it talks about primary health care, it talks about satisfaction of the health needs of the highest risk groups and of those whose poverty makes them the most vulnerable. I plan to explain the tradition of social medicine in Latin America, but I don't have time to do that. So some general principles of human rights that might lead us to certain ways of thinking about universal coverage. One is that economic and social rights, and health is an economic and social right, are to be progressively realized over time. It's not that it can be implemented from one day to the next in accordance with maximum available resources. So what constitutes universal coverage in Ethiopia is not going to be the same as what constitutes universal coverage in Norway. But they are going to be progressively realized, so the circle of services is going to be expanded. And retrogression, moving backwards, is presumed inconsistent. So once a certain level of services has been implemented, you can't move back. And this has been held in a number of different contexts by different courts, which I don't have time to go into. Again, interdependence with civil and political rights, such as the right to information, equal protection, of course, the right to life. But also, human rights doesn't have a lot to say about which particular services need absolute priority, but there is a prescription on torture, cruel, and human and degrading treatment, which is absolute and not progressively realized, and access to palliative care, or lack of access to palliative care, has been construed as cruel and inhuman treatment under international law. Multi-sectoral approaches. So you can't look at just the health sector alone. This became very apparent in a perverse way in Colombia when the Constitutional Court ordered a restructuring of the health system that included equalizing the subsidized regimes for children. And the government then decided to take out family planning, counseling, and services from public schools for adolescents and put them in what was going to be the subsidized health plan, which of course would have reduced access. So when you're thinking about what services are available, you have to look across sectors in a broader way. And also, of course, a human rights framework means that there should be some legal recognition. It is an entitlement. It is not at the largesse of government, and it should be legally enforceable. This is not the case in many countries, but it is absolutely, there is an increasing trend for courts to convert directive principles into enforceable rights and to enforce entitlements to health care as well as healthy conditions across middle-income countries and increasingly low-income countries. Okay, last slide, I guess. Principles toward moving toward universal coverage. It's really, in human rights law, they talk about availability, so equitable availability of health facilities, goods, and services, geographically equitable. Accessibility on a basis of non-discrimination, economic accessibility as well as physical accessibility, cultural and ethical acceptability, and quality. And I want to stress this quality criterion because it's not just, for example, that there's access to family planning services, but those family planning services need to be provide for confidentiality, informed consent. Certain minimum standards of quality are, in some sense, as important as what services are available. The process for setting up priorities needs to be participatory and transparent. I've written a lot about this as being broadly consistent with what Norman Daniels talks about in terms of accountability for reasonableness. So something that is not left to technocrats, but that the people actually affected by the decisions have a voice or a say. There are other principles. There's special concern for marginalized and vulnerable groups. The special concern is for different reasons. So a lot of people think, oh, all of these groups should get equal priority in terms of health care, and that's not actually true under human rights law. So prisoners are special because they're in the custody of the state, so they get special priority. Children and pregnant women have a special status under international law. But say other stigmatized groups like men who have sex with men, if you actually responded to that stigmatization or discrimination by providing greater priority in health care, you might actually be exacerbating the discrimination, the ideas of, oh, these people have greater incidence of HIV or of sexually transmitted infections, for example. So the response would be reducing the stigma and discrimination, decriminalizing certain activities rather than prioritizing access to health care. Because the overall goal is a broader equity goal, not just in health care. So those who would be prioritized generally are those who lack access because of economic reasons, physical reasons, or any form of discrimination. Discrimination under human rights law is generally thought about in terms of prohibited grounds, not in terms of personal discrimination. I don't have time to go into that. And there's two kinds of equality that are considered. Formal equality, which really advocates strongly for the idea of universal systems, that all similarly situated people will be treated equally, but there are some exceptions to that when substantive equality requires that effective enjoyment of rights requires differential treatment. And I guess I'll just stop there. Thank you.
So while we're getting the next presentation, thank you. I think yesterday, Ula and Dan, you said your objective was about deliberating so that we can make choices with responsibility. So thank you for putting some principles, reminding us that the health system is a social actor. Yesterday's theme was about attacking the cube, and I think we're seeing now is we're going to redo the theme to shaking up the cube. So where's Tessa? I know. Yes, I know. I was just because I sort of see Tessa as the cube point. But I had a slide on attacking the cube. So the next presentation is, I think a lot of you know Dr. Eyal. He is an associate professor of global health and social medicine at the Harvard Medical School. And Nir has, prior to joining Harvard, he was a postdoctoral fellow in bioethics at the Center for Human Values at Princeton University. And I think Nir is going to be talking to us about choices.
So several speakers yesterday discussed, this is coming up, suggested we discuss more today and emphasize in ethical discussions the sort of hard choices that we need to make for trade-offs between the different dimensions of the cube, between other things that we value that might fund expansion of various dimensions of the cube. And this talk will be on the option of rationing along the breadth, the population dimension of the cube, trade-offs that focus on that. Thanks a lot. Thank you. So,
Right forward, left back.
thank you.
Here's laser.
Okay, thank you. So, I think it is usually assumed that this dimension is something that you shouldn't touch. You don't make your rationing decisions, your painful trade-offs, if you want universal coverage, by sacrificing the dimension that gave universal coverage its name. You know, give some people, not to others. Consider it better to somehow do it other ways. What I'm going to do today is to argue to the contrary. So if you think of the possibility of covering some of the people all of the time, or all of the people some of the time, for most people, certainly the latter is fair. I will argue that actually the former is fairer, better, and ethically very low-lying fruit if you have to make some concessions anyhow. In fact, I wouldn't even call it a trade-off, so it's definitely a good place to start. I should call this way to ration selective facilitation, or I could have called it targeted facilitation based on a presentation earlier today. What do I mean by that? By selective facilitation, sorry, am I speaking here? Okay. By selective facilitation, I mean phasing off the public pooled fund support facilitation in the form of providing services, in the form of providing funding, coupons for that you can take to the doctor to get your services, facilitating an insurance system that gives you the coverage you need. Yeah? Phasing off all that for low and middle cost services around the income percent that gives a person full access to these services. What do I mean by full access? I mean they become fully affordable to you. At that point, you're rich enough to buy your own. You can fend for yourself. You will maintain your full access. You can afford it. It will not drive you into poverty. It will not be a catastrophic payment. If that's necessary, an insurance system is something that the private market, I must assume, will exist in such circumstances. You can take care of yourself and buy these services even without the facilitation from the government or from other public agencies. So some notion of what that might entail. For example, if we want to be able to provide cheap cataract surgery to all poor people across the country, and that can become very hard once we're talking about very remote areas, it can become a big investment per patient, we can withhold that from, it's a painful decision, but still I think it's worth it, withhold that from the middle class and the rich who can buy their own. Or talk about a middle cost intervention, leukemia treatment in the most basic universal coverage systems. They often have to forego that, but that's kind of the next stage. You could provide that to the poor and the middle class on the assumption that it's not so expensive, the rich can buy for themselves. what you buy yourself by excluding the rich, difficult decision to make, is that you enable people who otherwise wouldn't be able to get it, because it is it is above the cutoff for most interventions in very resource-strained systems. You buy them that treatment. So know that this proposal is about low and middle cost interventions. I think high cost interventions are very complicated because of the issues that the catastrophe session was about yesterday. Financial catastrophe, I'm not going to discuss those. They need an independent solution anyhow. All right, what is the basic case for this? Well, if you save on the facilitation for those who can afford it, you have more money to cover those and protect more the health of those who don't have the resources, and it also has advantages in terms of the distribution of income. So let me quickly elaborate on these. In terms of health, first, if you save on the insurance for the rich, you keep more money for assisting the poor. So leukemia example, there are other examples. You also know that in many systems, as we have heard this morning, when the intervention is for everyone, the rich, in effect, use it more, so that you kind of get rid of that inequality in terms of income, of health as well. So know that this is not just a matter of what we have called efficiency, it's also a matter of equality. You also redistribute in a more just way if you provide your services in a targeted way. Now move to income. You're left with more money for the poor. You can therefore lower the user fees that the poor might pay. You can also, you should also remember that the rich who will have often funded that system in the first place through taxes, through premiums, they take back less. So there is a redistributive effect, again, a matter of fairness, not just of efficiency, moving the money to the people who get a greater bang from every buck. There are two senses to the word coverage, and therefore two senses to universal coverage. When WHO speaks about coverage, and I owe Trygve Otterson pointing my attention to this, they mean access to key interventions at an affordable cost. But that's not what coverage means in English. For me, it was very bewildering because I didn't quite see what they might mean. So here's an example that Alex Verhove gave me. Alex is covered under the NHS for medical expenses, not for dental expenses, in the following sense. Not in the sense of WHO that he doesn't have access to dental care. He has access because he can fend for himself. He can buy his own. He gets coverage in the sense that, in a very different sense, therefore, from the one that WHO uses. I think that this linguistic model matters a lot because it hides important ways that we could promote coverage in that first sense, which I agree with WHO is very important, giving everybody access to affordable services. That matters a lot, by using means that stray away from universal coverage in that second sense. Yeah, okay. So there are different ways to achieve universal access, what WHO calls universal coverage. And there are ways to do, I think there is some kind of, there might be some problems of coordination between this system and my computer at home. So there are ways to do that with services provided to everybody. That would be what coverage means in universal coverage would mean in English. Dean Jamieson yesterday, I think, when he told us about universal coverage, meaning universal public finance, was thinking of providing services to everybody. So he was using universal coverage not the way WHO uses it, but the way one should use it in English. Here's a paradigm system that provides services to everybody, a system from Brazil. Everybody can get that. There is free services, free clinics. You go in, there is no means testing. if the rich wanted to, they could get that service. That's universal coverage in the very, very strict sense of there is access because it's provided. But there are ways to provide access without that, without actually providing the service. And what the linguistic blunder does is to obfuscate many ways to do so without actually providing everybody with the services, actually providing them with funding. It also creates confusions, I think, in the World Health Report. The orange uses of covered, and especially the red uses of cover, I think actually steer away from WHO's use of coverage. Let's not go into this. But you might object to, you might say, okay, there is some kind of logical space to this, but there are good objections to trying to achieve universal access through means other than giving everybody the intervention they need, giving everybody the funding for that intervention. So for example, you might think that all this means testing and monitoring creates problems. You might think that services that are targeted only for the poor will become underused because of stigma. You might think that the rich won't support them enough, so politically they would chronically become underfunded. You might worry that the rich will poach health workers. You might worry of a poverty trap, and you might worry about not treating everybody equally. I'm going to elaborate just on some of these points. So is it really a big concern that there would be some effect, if there would be, of shaming, of inefficiency having to do with this? I think that the benefits that we can reap out of targeting are totally worth it. I'll also mention that there are other ways, less shaming ways. It's not necessary to shame if you want to glean people's incomes and monitor. I'll move quickly to the next slide just to kind of save us time. I will mention that there are some indirect ways that you can try to target the poor without actually calling the recipients poor, and we could discuss that during the questions. All right. Are services only for the poor necessarily stigmatized to the degree of being underused? Again, think these are key health interventions. Would the poor feel so ashamed that they would simply not use something like leukemia treatment for their children? Occasionally, maybe yes, but I think it's worth it in balance if you provide many services that otherwise would not be available. It's also important that for some of these services, we can actually include the middle class. And I believe that when the middle class is inside, not the rich, the middle class, that detracts a lot from any potential stigma. Think about many Medicare services. In fact, the filthy rich, yeah, they're entitled to them, but they don't really make use of them. They go to their private doctor. That doesn't mean that using Medicare is shaming or stigmatizing and underused. Think of mixed housing. Food stamps used to be stigmatizing. Now, in this recession, the middle class is also using them, and we have evidence that the stigma is going down, and people use them. Underfunding, again, there is evidence that this is not happening in some universal coverage systems. It's also the case, I think, that when, from a political standpoint, when people who badly need the services are the ones who receive the service, and there are no examples of very rich people who abuse the system by getting services, that helps politically as well, helps stability. And besides, when the sharp-elbowed middle classes are on board, again, that is often what politically matters. I will skip this. I will also skip the poverty trap aspects. I'll finish just by discussing the last point. This doesn't treat everybody equally, you might worry. Philosophically, I think what matters is not so much treating everybody equally, but showing equal concern, if anything. And you show equal concern by giving those who need a service that service. You lose some opportunity to convey very palpably those kind of, we are all citizens, you all have rights, you all have entitlements. But I actually think that the message, we are the 99%, or we are the 50% who are here to fight for our rights, makes often a lot more sense than the message, we are the 100%. So I actually don't have a problem with that message. So to conclude, this is often the lowest lying trade-off, if you will, from an ethical standpoint. You can definitely start with that. And that population dimension that many people think of as the last resort should be the first resort. Thank you.